6 surgeries exist for your prostate. Your doctor probably named one, maybe two. That's not their fault. A 15-minute appointment can't cover this, but you're here now, and by the end of this video, you'll know which one actually fits your life. I'm Dr. Adriana Wells, urologist. I've spent over 2 decades sitting across from men just like you, men who came into my office holding a referral slip, eyes a little wide, not sure what question to even ask first. And here's what I've noticed. Almost every single one of them knew one surgery, TURP. Maybe they'd heard of a laser, but that was it. 6 options, and they knew one. Right now, you're probably thinking, my doctor's good. Wouldn't they have told me everything? Here's the truth, and I say this with genuine respect for every physician out there. Your doctor is good. The problem isn't your doctor. The problem is time. 12 minutes. That's the average urology appointment length in America. You can't map 6 surgical options, explain the trade-offs, assess your anatomy, and answer your questions in 12 minutes. It's not possible. So men leave with a name, a surgery name, and they Google it at midnight, and they find horror stories, and they get scared. And sometimes they wait too long because the fear of the unknown outweighs the misery of waking up at 2, 3, 4 in the morning to stand at that toilet and wait. I know that feeling isn't just physical. It seeps into everything, your sleep, your mood, the way you look at your partner across the dinner table and think, I don't want to bring this up again. Before we go any further, drop your age and the state you're watching from right now in the comments. I read every single one, and I genuinely adjust future videos based on who I'm talking to. So tell me who's here. Here's where it gets dangerous. When men wait too long, the bladder changes. The muscle that pushes urine out has been working against a wall for years, and sometimes, even after we remove that wall, the muscle is too tired to spring back. That's why I'm going to give you what you should have gotten in that appointment, all of it. Let's talk about what's actually happening inside your body. Because once you understand the mechanism, every single surgical option I describe will make perfect sense. Your prostate sits right below your bladder. It wraps around the urethra. That's the tube that carries urine from your bladder to the outside. Now, imagine a garden hose. Clear, water flows freely. Now imagine someone slips a rubber ring around the middle of that hose and squeezes. The water slows, it trickles, sometimes it stops. That's BPH, benign prostatic hyperplasia. It's not cancer, it's not a crisis, it's growth. The prostate naturally grows as men age, and in most men it's the inner zone, the zone wrapped tight around the urethra that grows fastest. By your 60s, half of all men have meaningful enlargement. By your 80s, it's closer to 9 in 10. Now here's what matters more than size. It's the shape of the blockage. 3 things determine which surgery will work for you. 1. Prostate size. Small, medium, or very large. Different tools work for different sizes. 2. Whether you have what we call a median lobe. Picture a little doorstop that's grown up into the base of your bladder, blocking the drain from the inside. Some procedures handle this well, some don't. 3. How much ejaculation matters to you? I know that can feel like a hard question to say out loud, but it matters medically, and it matters for your quality of life. And I'm going to be honest with you about each option. For years, the conversation in urology went like this. Try medications first, and when those stop working, come back for surgery. And that's still often the right path. But I'll tell you something I've learned that changed how I counsel patients. The men who do best, physically and emotionally, are the ones who understand all their choices before they're in a crisis. This is the moment I want you to hit subscribe, not because it helps my numbers, though it does, but because what I'm about to walk you through is the kind of information that used to live only inside a urology textbook. I put out a new video every week on the topics that matter most to men in their 60s and 70s. This channel exists for one reason. So you walk into that doctor's office knowing your options. That's it. Hit subscribe, then stay with me. Let me tell you about a man I'll call Robert. He was 68, retired electrician from the Midwest, came in with 2 years of symptoms that had been getting steadily worse. Weak stream, waking up 3 times a night, that constant feeling that his bladder was never quite empty. His primary care doctor had started him on an alpha blocker to relax the prostate muscles, and it had helped some, but not enough. Robert sat down in my office and said, "I've been on this pill for 2 years. I don't want to be on it for another 20. He'd heard about TURP from a neighbor. That was the only surgery he knew about. One word, one option. When I told him there were actually 6 different surgical approaches, and that given his anatomy and priorities, he was actually a very strong candidate for one of the minimally invasive options, his whole body relaxed. He looked at me and said, "Why didn't anyone tell me this before?" That's why I'm telling you now. Let's go through all 6. I'm going to give you each one's mechanism, who it's best for, what the trade-offs are, and one thing nobody tells you before you choose it. Option 1, Rezum water vapor thermal therapy. Picture this, you're in the office, light sedation, some men are awake, just drowsy. The entire procedure takes under 10 minutes of active treatment time. I guide a small device through the urethra. A burst of steam, water vapor at 103 degrees Celsius, is injected directly into the enlarged prostate tissue. Seconds per injection. Usually 3 to 5 injections total. What happens next is the part that surprises people. Nothing, not immediately. The steam kills the overgrown cells, but the body absorbs that tissue slowly, over 6 to 12 weeks. So you go home thinking, that was fast, when do I feel better? And the honest answer is, not yet. The first 2 weeks can actually feel worse. Swelling, urgency, burning. Most men need a catheter for 5 to 7 days. That temporary frustration is real, and I tell every patient to expect it. But by 12 weeks, the data is strong. Men who have Rezum show clinically meaningful improvement in symptom scores, and the results hold up at 5 years in most cases. About 14% will need a second treatment within 5 years. That's important to know going in. Who it's for: men with prostates in the small to medium range, men who value quick recovery and want an office procedure, men for whom ejaculation preservation is a high priority. Retrograde ejaculation is rare with Rezum, under 5%. What nobody tells you, the catheter phase feels worse than the procedure itself. Plan for a week of disruption. Have someone drive you. Stock the freezer. Option 2. Urolift, prostatic urethral lift. Urolift is unique. Nothing is removed, nothing is destroyed. Instead, small permanent implants, each about the size of a staple, are placed through the urethra to pull the prostate lobes apart like opening a curtain. The channel widens, urine flows, the appeal is obvious, office procedure, no heat, no tissue removal. Many men go home without even a catheter. Ejaculation preservation rates are the highest of any surgical option, over 95%. But here's what the brochure doesn't always say clearly. Urolift is anatomy specific. It works best for men with a prostate under 80 grams and no significant median lobe. Retreatment rates are somewhat higher than more definitive surgeries, about 13% within 5 years. But the deeper question is, what does retreatment mean for you? For a 64-year-old man who travels internationally and can't afford 2 weeks of recovery, doing Urolift now and possibly retreating at 70 might be a completely reasonable choice. That's individualized medicine. That's what this conversation is supposed to be. Who it's for: men who want ejaculation preservation as their top priority, men with smaller prostates and no median lobe, men who want the fastest recovery and the least disruption to daily life. What nobody tells you, the implants are permanent. They don't hurt. You won't feel them. But if you later need a different surgery, the presence of implants can make that technically more complex. Option 3. iTind, temporary implantable nitinol device. This one is newer. iTind is a small device made of nitinol, a shape memory metal. It's placed in the prostate through the urethra and left there for 5 to 7 days. During that time, it gently expands and remodels the tissue around it, creating a more open channel. Then it's removed in the office. No anesthesia needed. No permanent implants. No tissue removal. Sexual function preserved. Recovery is typically minimal. Best suited for smaller prostates, generally under 75 to 80 grams, and specific anatomies without significant median lobe. Long-term durability data beyond 5 years is still developing, and I tell patients that honestly. What nobody tells you, you'll have a temporary stent-like feeling for the 5 to 7 days it's in place. Most men tolerate it fine. Some find it uncomfortable. Ask your surgeon what to expect specifically. Now, I want to stop for a moment. We're halfway through, and I need to hear from you. Type 1 in the comments if the nighttime urination is your biggest problem, waking up 2, 3, 4 times. Type 2 if it's the weak stream, the pushing, the waiting. Type 3 if it's that feeling that you never quite empty, that heavy, uncomfortable fullness that just won't go away. Your answer matters. It helps me understand what this community needs most. Option 4. Aquablation, robotic waterjet therapy. Aquablation is done in the operating room under anesthesia. A robotic system uses a high-pressure saline jet, guided by real-time ultrasound, to precisely carve away excess prostate tissue. The actual tissue removal often takes under 5 minutes for even a large prostate, and the precision is remarkable. The surgeon maps the tissue to be removed before the robot executes. Aquablation treats prostates up to 150 grams, that's a big prostate. Ejaculation preservation rates are better than TURP, roughly 75 to 80%, though not as high as Urolift or Rezum. Bleeding risk is higher than office-based procedures, and a catheter is required for a day or two. Who it's for? Men with large or very large prostates. Men who want a robotically precise procedure with good ejaculation outcomes. Men who are comfortable with a brief surgical setting. What nobody tells you, the robot does the cutting, but a surgeon is at the controls the entire time. The skill of your surgeon still matters. Option 5. TURP, transurethral resection of the prostate. TURP has been the gold standard for BPH surgery for over 60 years. I perform them regularly. When it works fast, and it works well. Under anesthesia, I pass a scope through the urethra. An electrified wire loop shaves away obstructing prostate tissue in small pieces. The channel is physically widened. Once the catheter comes out, usually 1 to 2 days later, most men notice immediate improvement in their stream. But here's what I wish I'd said more clearly earlier in my career. Retrograde ejaculation happens in the majority of men after TURP, somewhere between 60 and 90%. That means at orgasm, semen goes into the bladder rather than forward. Erections are typically unaffected, but the ejaculation change is permanent. I've sat with men after TURP who said nobody told them clearly enough. That's on us as physicians, and I'm telling you now. Who it's for? Men with moderate to large prostates who want highly effective, durable results. Men who are not concerned about retrograde ejaculation. Men who have already tried medication without adequate relief. What nobody tells you, TURP has excellent long-term durability. 10-year retreatment rates are significantly lower than many minimally invasive options. If you want the highest probability of never needing a repeat procedure, TURP and HoLEP are your 2 strongest candidates. Option 6. HoLEP, holmium laser enucleation of the prostate. This one surprises almost everyone who hears about it. HoLEP is, in my clinical opinion, one of the most technically impressive BPH procedures available today, and it's the one most men have never heard of. Here's the concept. The prostate has an inner zone, the part causing all the problems, and an outer capsule. In HoLEP, I use a holmium laser to peel the entire inner portion away from the capsule, like removing the flesh from an orange without touching the rind. That tissue falls into the bladder, a second instrument shreds it, and it's suctioned out. Complete. Thorough. No remaining obstructing tissue. HoLEP works on prostates of any size. 40 grams, 140 grams, 300 grams. It doesn't matter. Retreatment rates are the lowest of any endoscopic procedure. Bleeding risk is lower than TURP. Hospital stay is typically just 1 night. The trade-offs. Retrograde ejaculation is common, similar rates to TURP, and there's a learning curve for surgeons. Not every hospital has a urologist trained in HoLEP. Ask specifically before assuming your surgeon is experienced. One more thing I tell patients. Temporary stress urinary incontinence can occur in a small percentage of men immediately after HoLEP. In the vast majority, this resolves within weeks to a few months. It's worth knowing about going in. What nobody tells you, HoLEP outcomes are highly surgeon dependent. Ask the number directly. How many has your surgeon done? A good urologist will be glad you asked. Now, 6 options on the table. Here's how I actually help patients decide. I call it the 4-question framework, and I draw it out in the office. Question 1. How large is your prostate? Under 80 grams, all 6 options are in play. Over 80 grams, Rezum and Urolift become less ideal. Over 150 grams, HoLEP is often the best choice. Question 2. Do you have a significant median lobe? If yes, Urolift and iTind become more challenging. Rezum, Aquablation, TURP, and HoLEP are better suited. Question 3. How important is ejaculation preservation? Very important. Look at Urolift, Rezum, or iTind. Somewhat important, consider Aquablation. Not a primary concern, consider TURP or HoLEP for maximum durability. Question 4. How much recovery can you tolerate? Back to life in days, look at Urolift or iTind. A few days to a week, consider Aquablation or TURP. Willing to rest 2 to 3 weeks for best long-term outcome, HoLEP is worth discussing seriously. Between you and me, and I say this carefully because individual anatomy always matters, if a man came in with a moderate-sized prostate, no median lobe, and ejaculation was still important to him, I'd look hard at Rezum. If he had a large prostate and long-term durability was his top concern above all else, I'd talk seriously about HoLEP, not because the others aren't good, because those two match specific profiles with strong evidence behind them. Before you make any decision, write these questions down and bring them to your appointment. What is my prostate size in grams, and do I have a median lobe? Which of the 6 surgical options do you perform yourself, and how many have you done? What is your personal complication rate for this procedure? What are the realistic chances I'll need a second surgery within 10 years? What does recovery look like specifically? Catheter duration, activity restrictions, timeline to feeling normal. What happens to my sexual function, specifically ejaculation, with this procedure? Those aren't confrontational questions. A good urologist will be glad you asked them. Here's something I want you to know about red flags. Situations where waiting is no longer the right call. Talk to your doctor urgently if you suddenly cannot urinate at all and need a catheter to drain your bladder. If you've had 2 or more urinary tract infections in the past year tied to incomplete bladder emptying, if you have visible blood in your urine more than once, if a kidney function test shows your kidneys are being affected by the backup of urine, these aren't meant to scare you. They're meant to give you permission to say, "This can't wait." Here's the single biggest mistake I see before surgery. Men wait until they're in a crisis to decide. A catheter is in. They're exhausted. They're scared. And they make a surgery choice in that state, under pressure, without having thought through what matters most to them. Don't let that be you. If you're watching this video, you have time. Use it. Let me tell you about a man I'll call Gerald. 71, retired. His prostate was measuring over 120 grams, very large. He'd been on 2 medications for 4 years. They'd stopped working. His primary care doctor had referred him for TURP. Gerald came to me for a second opinion. When I told him his prostate size actually made him a strong HoLEP candidate, better durability, lower bleeding risk at his size, and though ejaculation would change, erections were very unlikely to be affected, he went quiet for a moment. Then he said, "I've been afraid of surgery for 4 years. 4 years of bad sleep. 4 years of being embarrassed at dinner with my grandkids because I have to get up every 45 minutes. He paused. If this is the right tool for my prostate, I want the right tool. Gerald had his HoLEP 8 months ago. He sleeps through the night. He golfs 3 mornings a week. He called my office not to report a complication, but to ask if it was okay to send a thank you card. That's what the right information does. It gives men their lives back. Tonight, write down your 3 worst symptoms and how often they happen. Rate each one on how much it disrupts your life, 1 to 10. Tomorrow, Note how many times you woke up last night. That's your baseline. This week, call your urologist's office and ask specifically about your prostate size, whether you have a median lobe, and what surgical options they offer. If they only offer one, you have the right to ask about others or to seek a second opinion. 6 surgeries, 4 questions. 1 goal, your life back. You came in thinking surgery was one scary thing. It's not. It's a spectrum. Somewhere on that spectrum is a tool that fits your prostate, your body, and your life. Drop 1 word in the comments right now. Ready. That's it. 1 word. Then, hit subscribe because next week's video is about something most men with BPH are also dealing with and you do not want to miss it. Everything in this video is for educational purposes only. I am not your doctor. Please consult a qualified urologist before making any medical decisions. Individual results and treatment options vary based on anatomy, health history, and clinical assessment. All patient stories shared are composite cases. No identifying information has been used. Your privacy is protected. This video was produced with AI-assisted tools in its creation process. All clinical content was reviewed and directed by a licensed medical professional.